Good evening. It is a pleasure to talk to you today. My name is Poonam Jain. I'm a general dentist with a master's in operative dentistry and a master's in public health. I've been in education for 26 years, currently serve as the Vice Dean for Clinical Affairs and Advanced Dental Education at A.T. Still University. I still maintain a private practice in general dentistry, and actually I am at that general practice office at this moment. So this evening, we're going to talk about glass ionomer materials and how to use them to their fullest potential in your practice. And then at the end of the session, we'll reserve a few minutes for questions and answers. So just a quick picture of A.T. Still University. This is the clinic building, the St. Louis Dental Center, as we call it, in St. Louis, Missouri. So traditionally, we've used these materials for a while. I mean, they've been around since 1971, but traditionally we've used them for very specific purposes, specifically, for high caries risk patients, and in general for class 3s, class 5s, and sometimes for, occlusal class 1 lesions. So to back off, and I'm going to try and remove this from the top. Let's see if I can get rid of this screen so you can see my entire slide. All right. Okay, I won't be able to do that, I guess. I'll leave it here. In any case, coming back to this, the ideal restorative material in all restorative situations in dentistry is one that would have some karyostatic properties, if possible, in the ideal universe, is easy to use. It's not too technique sensitive. It is somewhat forgiving at least, of compromised isolation, because as we know, it's very difficult to get 100% isolated situation in the very wet environment that the human mouth is. Of course, if it bonds to dentin chemically, I mean, that is now becoming more and more ideal of a situation and has a good marginal seal. That would be our ideal material if we could ask for one, right? So let's see what we have when we look at glass ionomers. Traditionally, we've had these materials with us. These are the oldest, materials from GC. Fuji 9GP came around. It was one of the first true glass ionomers that sets with an acid-base reaction. But still, these materials had their limited uses. Back in the day, this is an advertisement straight from the company, that has been making glass ionomers for the longest time that I know of, at least. Their advertisement shows an elderly person, like a grandfather with grandkids. The grandkids are looking up at the grandfather, and it shows a class 1, a one-surface occlusal cavity preparation here. And this is their own promotional materials. So really indicating that the material is ideal for, geriatric or pediatric use. Here, the pediatric teeth are not expected to serve for very long. And here, well, the person may not be around for very long, right? Nowadays, though, we have come a very long way in the evolution of these materials. We're using them in class 2 situations. There is evidence, very good long-term evidence from the literature suggesting that they perform as well as amalgams, comparable to composites in even class 2 situations on permanent molars. This year is an example of a class 1 and then a class 2 on a permanent molar, and this restored. And this is actually from the practice just yesterday, a patient from yesterday. But we'll talk more about that. I'd like to go over some basics, and I'll do a quick review of the material. So this is a quick one-on-one dental material review. So far as the composition of a true glass ionomer is concerned, it is a powder liquid configuration. Whether it is in a powder, with the powder and liquid are in a 2-bottle system, or they are in these compules. Again, this is a powder liquid situation with a plastic separator in the middle in the compule. And this is the traditional way of packaging them, of course. in either case, it is the same configuration, a powder, a liquid that must mix. So really, in the end, the reaction between the powder and the liquid is simply an acid-base reaction. The powder is an inorganic basic glass ionomers with a lot of ions. And this, gives you an example. There will be no quiz. The quiz questions will not ask about the chemical formula, but nice to note that it has silica, alumina, calcium fluoride, and we'll talk at length about fluoride, aluminum, sodium aluminofluoride, aluminum phosphate in the glass, in the powder. And then, of course, barium or zinc can be added to improve the radio opacity of the material. The liquid is always a weak solution of 47.5% solution of polyacrylic or polycarboxylic acid. Same thing, polyacrylic, polycarboxylic, same thing. That's the liquid. And it's kind of nice to note that this liquid that will mix with the powder during the setting reaction, remember whether it's in a 2-bottle system or the compute system, it's the same chemical that is used for conditioning the dentin or enamel, the tooth structure really, before placement. And so it's the same exact polyacrylic solution that serves both purposes. So if, there's a take-home message regarding the chemistry of these materials, I'm very proud of this, is, my slide, and I really like this very much. These materials, glass ionomer materials, are truly unique to the practice of dentistry. And we'll talk about why in a moment. But for the powder, historically, for our dental materials, dental cements, we had zinc oxide as a powder, and for the liquid, phosphoric acid. Nowadays, of course, we use phosphoric acid mainly as an etchant for composite resins, but when phosphoric acid was used as the liquid and zinc oxide as a powder, we obtained zinc phosphate cement. And we've used, some of us in this audience, I'm sure, have used zinc phosphate cement for luting crowns, for luting inlays, onlays in our practice. But when you take zinc oxide powder and switch the liquid and use polyacrylic or polycarboxylic acid, like I said, the same thing, we get polycarboxylate cement. And this is the first time in dentistry when we used polyacrylic acid with zinc oxide powder, we obtained a material that has a true chemical bond to tooth structure. So polycarboxylate cements, which are still available, Duralon is an example of such a cement on the market, have a true chemical bond, a weak one, but a true chemical bond, the first materials to have a chemical bond. If you take aluminofluorosilicate powder instead of zinc oxide powder and mix it with phosphoric acid, you end up with silicate cement. And once again, some of you will recognize silicate cement. This was the first aesthetic material that we ever used in dentistry. So it was not tooth colored, but it was white. And some of you might remember it was chalky white. It became sort of chalky and opaque, and it wore down really quickly. So it wasn't truly aesthetic, but at least it was white. It was not, metallic in color. Was used on anterior teeth in class 5, class 3 situations. Could not be used very successfully in class 4 situations because it didn't have enough compressive strength, to build up the incisal angle. The beauty of the silicate material, it revolutionized dentistry, not just because it was, white, could be used in anterior situations, but because this material wore down quite rapidly, but there was never any recurrent decay that could be found underneath. And it was figured out that was because fluoride was constantly leaching out from the material, from the set material, again, which is a great thing. It was karyostatic. However, it wasn't very stable because it, so much fluoride leached out that the material was inherently unstable. So therein come glass ionomer cements. To make the product more stable, then, the same powder was mixed with polyacrylic acid instead of phosphoric acid, resulting in glass ionomers, which we're talking about today. They retain the chemical bond to tooth structure, which comes from using the polyacrylic or polycarboxylic acid, and they have aluminofluorosilicate in the powder, So they release fluoride, but less so than silicates. So even though they have wonderful karyostatic properties, not the same as that of silicate cement, but much more stable. So best of both worlds, the fluoride release, the karyostatic properties that we had with silicates to a slightly lesser extent, but retained the chemical bonding to tooth structure. So truly unique materials that bond chemically to tooth structure and release fluoride, really release fluoride. So this is the chemical reaction again, and I won't dwell too much on it. It's an acid-base reaction, and very importantly, it needs water. The role of water for these materials cannot be overemphasized. Water is the reaction medium. You need the water in the liquid. The set cement is about half water. So these materials, goes without saying, gain and lose water rapidly. So if you're going to use them in an expanded way in your practice, as we're going to talk about, then this is a very important point to note, because while you're placing them, you cannot let them desiccate. So once more, the chief advantages are these materials, glass ionomers, are unique. They exhibit adhesion to tooth structure via a true chemical bond, and they have continuous and rechargeable fluoride release. Continuous and rechargeable. The other major advantages are the thermal coefficient of glass ionomers is similar to tooth structure. So you don't have the coffee ice cream syndrome. The patient drinks coffee, the restoration expands, the patient eats ice cream, or, they could have an apple pie with ice cream and coffee all at the same time. And there is constant, there is intermittent or alternating expansion and contraction of the material, which is different from the expansion and contraction of the tooth structure, resulting in marginal leakage, resulting in a lot of problems, sensitivity, recurrent decay. The other huge advantage of glass ionomer materials is that there is very low shrinkage when they're set. It's an acid-base reaction, not the polymerization reaction with, composite resins. So that, again, huge factor leads to good marginal seal. Lastly, but not the least, much more forgiving of moisture, much more forgiving than composites. I mean, composites are hydrophobic materials, whereas this material, glass ionomers, are inherently cements. And we just got done saying the set product is about half water. So these materials are much more forgiving, which doesn't, that doesn't mean that you can place them in a sloppy, wet environment with, gingival crevicular fluid or blood. But still, if you are, deep subgingival, you're on a deep subgingival surface, there is some crevicular fluid. These are much more forgiving, and you don't have to worry quite as much about getting a marginal gap and recurrent decay and sensitivity, post-operative sensitivity. I think that in the past 10, 12 years, since I've switched to using these materials almost completely for my posterior restorative work, I mean, the sensitivity, post-op sensitivity, I've hardly ever heard a patient complain after placing a glass ionomer restoration. Hardly. Whereas that used to be quite a common occurrence when, I primarily did composite resins on posterior situations, class 1s, class 2s. So the carboxyl group from the polyacrylic or carboxylic acid reacts with calcium ions from the tooth structure, enamel, or dentin, and results in the chemical bond, which is about 6 to 12 megapascals in strength. So it's not a very strong bond, but it is a true chemical bond. It's not a mechanical bond as with composites, not a micromechanical bond at all. True chemical bond. The caries inhibition from glass ionomers due to the fluoride release is really, really beneficial in a dry mouth situation. And, as we all know, we see more and more patients with dry mouths due to polypharmacy, all the medications that, most of our patients are on, due to radiation therapy, chemotherapy, Sjogren's syndrome, what have you. But really polypharmacy coming first. followed by radiation therapy. And then rampant caries. Even though, the incidence of caries has gone down, as we all know, rampant caries is still alive and well in quite a sizable proportion of our population, whether it is due to poor dietary habits, whether it is due to lack of hygiene, a combination of the two. And then root caries. As longevity increases and we keep our teeth or more teeth for longer, of course, there is gingival recession, with age and due to other factors. And once root dentin is exposed, root caries, the risk for root caries is very high because root dentin is very susceptible. And can you imagine the combination of, exposed root dentin combined with a dry mouth due to any one of these reasons here, polypharmacy, radiation therapy, what have you? And that is the perfect recipe for a very high risk for caries. So in a situation such as this, as you can see, there's rampant caries. And this person, of course, is drinking at least 6 or 7 sodas a day. But this is a situation where glass ionomers are the material of choice for all direct restorative work. Now, of course, anything that has advantages has disadvantages. The chief disadvantage of these materials, among others, in anterior use, whether it is for class 3s or class 5s, is aesthetics. Compared to composite resins, they lack translucency. Even though they have come a long way in their evolution, still, compared to composite resins, they're nowhere close in their translucency. In their handling properties, and some dentists, report that to be their biggest obstacle in the use of glass ionomers in the clinic, it's the tug back. They're sticky. When you place them with an instrument, they tug back with the instrument. So there's a little bit of a trick to using them, and we'll talk about that. And then, of course, in posterior situations, in load-bearing areas, the wear resistance is of, some great concern. And many people, many dentists will still remember to this day, they say, well, we use them as long-term temporaries because their wear resistance is not up to par. They're comfortable using composite resins for large, class 2s, MODs, MODBLs for core buildups, but not glass ionomers because, they remember those old studies where the wear resistance of glass ionomers was of concern. So we'll talk a little about that, and compressive strength. So again, the compressive strength cannot be compared to that of metal. No, not at all. They're much lower in compressive strength, and their compressive strength is lower than that of composite resins. So that is a disadvantage. Again, we talked about, this promotional material from the past. For these reasons that we've just discussed in the past, they were advocated, they were sold only for pediatric and geriatric uses. But we'll talk about why that is no longer the case. The basic categories of glass ionomers are true glass ionomers, and then resin-modified glass ionomers, where 20% or less of the material is composite resin, polyacid modified resins, where more than 20% of the material is composite. And really, polyacid modified resins are, we're not going to discuss them because in the end, they're composite resins. So if they have a little bit of glass ionomer in them, once you've bonded the material using a bonding agent, you cannot hope for any fluoride release or any advantage of the chemical bond. So really goes without saying that might be just a marketing, gimmick there. We will talk about resin modified glass ionomers though. As we said, more than 80% of the material is a conventional glass ionomer, and then 20% or less is composite resin. So the resin is added to overcome some of the problems that we talked about while maintaining the advantages, the chemical adhesion, the fluoride release of true glass ionomers. So trying to get to, best of both worlds here. Example of this material that is in very common use is Fuji 2LC. And I think a lot of, you in the audience are probably using it or have used at some point Fuji 2LC. So resin-modified glass ionomers, in a nutshell, are better than conventional glass ionomers, but still inferior to composite resin for most physical properties. Okay, better tensile strength, better compressive strength, flexural and shear bond strength, than conventional glass ionomers. Still not as high as that of composite resins. Increased wear resistance compared to conventional glass ionomers. But we'll talk about how conventional glass ionomers have dealt with the problem of wear resistance. And of course, working time, once you add composite resin, here you add the letters LC, this becomes a light cured product. And to some, and a lot of my pediatric dentist friends rather, really like Fuji 2LC, will use it over and above a true conventional glass ionomer only because it will set once hit with the light. So if you have a little squirmy kid in your chair and you're trying to fill 2, 3, 4, 5, preps all in one go, they prefer zapping each with the light rather than waiting for, the 2.5 minutes that it takes, at least 2 minutes for a conventional glass ionomer like Equia to set. I, on the other hand, I see a lot of kids in my practice, and I prefer the true glass ionomer for the reasons, basically, of moisture forgiveness. It's very difficult, if possible at all, to get good isolation in a little squirmy kid's mouth. And there, the forgiveness of that moisture that you might get, that you're likely to get, of the true glass ionomer is much more important to me. And to me, the 2.5 minutes of working time that it takes for the true glass ionomer to set is really not that critical. But again, that's in my hands, in my practice. So RMGIs, the resin-modified glass ionomers, traditionally, they perform better than conventional glass ionomers when used as bases under restorations, whether the restoration is amalgam or composite resin. You can place these, of course, using the open sandwich or the closed sandwich technique. And let's look at some pictures here. In the open sandwich technique, then in a class 2 preparation, you'll bring the base, and here this is showing, the glass ionomer as a base. You bring it all the way out to the cavo surface, therefore the open sandwich. But in order to get the best of both worlds, the composite resin is placed on the top because of its wear resistance. Okay, primarily because of its superior wear resistance. But here in the most sensitive part of the preparation, this is the most sensitive part of the preparation at the gingival floor, especially here at the cavo surface of the gingival floor. This is where leakage occurs. This is where the gingivae are. This is where it's very difficult to get a good dry working field. This is where most likely, you could be subgingival or on root dentin, and you're not going to get a good bond. You're not going to get a good bond with composite resin on root dentin in these compromised areas, compromised situations. Here is where the open sandwich technique using a glass ionomer is the best idea. In the most vulnerable part, a lot of people have talked about using a flowable composite here, and I always say that is one of the weakest materials to use in this situation. It is the least filled, a flowable composite that is. It shrinks the most because it is the least filled, and we're placing it in an area where it would be very difficult to get good isolation. So this is one of the areas where I really, really recommend using the open sandwich technique. Now, in the closed sandwich technique shown here, you'd use the glass ionomer, but stop short of the cavo surface. Cover the yellow here is the composite resin. Cover the entire, as you would in a closed sandwich. The entire restoration is covered with composite resin. And again, I'm okay with this because if there is leakage, which there most likely will be, there is glass ionomer right here between the pulp and the the oral environment. Still, this is my favorite recommended technique, and not just mine, but it has been shown in the literature to be more successful. So looking at, this review here from the International Journal of Innovative Research in Science, Engineering and Technology, the open sandwich technique with glass ionomer cement, a critical evaluation. And, I'm not going to read all these studies, but just to give you a flavor, they reviewed the literature and found in each case the open sandwich technique to outlast the closed. So quickly going over the technique of placing Fuji 2LC as a base, about a millimeter thick on the pulpal floor, and then the axial wall, the pulpal floor, and then going down the axial wall. And here you see very nicely, we've taken the Fuji 2LC down on the axial wall. So the pulp is really protected by a material that bonds chemically, that releases fluoride, and that is extremely biocompatible in this situation. So placement in a class 5 cavity preparation, and you could use Fuji 2LC, which is a resin modified glass ionomer, for the reason that pediatric dentists like it. You can zap it with light, 20 seconds, and it cures. Or you can use a true glass ionomer, and we'll talk about it. But it's not very different than a composite resin in the first few steps. Select the shade, remove decay. Roughen the sclerotic dentin after decay removal is completed with diamond burrs. Always roughen the sclerotic dentin if there is any with diamond burrs. And then a deep small bevel in enamel. No bevels ever in dentin, but a deep bevel in enamel. A shallow bevel, unlike composite resins, doesn't work with glass ionomers, because if your bevel is shallow, if it feather edges, glass ionomers will chip off in thin layers. It will chip off. I mean, that is a given. And that is probably the chief complaint you'll have from your patients. Oh, it chipped off, doctor. The filling you had put, it broke, it chipped off. Because if you have the bevel too thin in a class 5 area, that's very likely to occur. So this is a good example. Very little decay, no decay, carious lesion, or carious, non-carious lesion here. Small amount of caries here, deep, small bevel in enamel, no bevel in dentin, no bevel on the root dentin at all. That's what I mean when I say no bevels on dentin. And then you can bulk fill it. Of course, here you're light curing it because it is Fuji 2LC. Very importantly, before placing it, you'll dry the tooth structure, but not desiccate it. So dry it, but don't bone dry it, okay? And that is important. Always use the GC conditioner. We're using Fuji 2LC. It's a GC product, but always use the conditioner. If you're using a product from any other company, which is a resin modified glass ionomer, use the conditioner. You'll recall that the conditioner is the same chemical as in the liquid. It is polyacrylic or polycarboxylic acid. Acidifies the tooth structure a little. The bond is more than 30% better. And that has been shown to be true. Whenever I'm talking to general practitioners, I hear a lot of them are not using the conditioner at all. So I do highly recommend, because this has been shown over and over again to increase the bond strength. So here it is. This is from GC, the dentin conditioner. Whichever RMGI you use, be sure to use the conditioner. So here it is. If you're using a capsule, you'll activate the capsule, triturate it using an amalgamator, 11 seconds on the old amalgamators, or the setting number 3 on the new amalgamators. Use your capsule in your applicator gun, inject it where necessary, bulk filling it, sculpting. This, step number 5, this is important. We talked about tug back. We talked about the material being sticky and the handling properties being a little bit of a problem. A lot of people complain about the handling property and the material being sticky. So this is important. You'll sculpt it. And I sculpt it to where I get it so that I'd never have to go back and finish it. I mean, I won't use the word never, but hardly ever have to go back and finish it with a burr. If you can avoid having to finish your glass ionomer or resin modified glass ionomer with a burr after placement, if you can sculpt it, do it. Because every time that you use a burr to go back and finish this, you'll introduce micro cracks. So every time that you can sculpt it to where you want it, do it. But use an alcohol wetted instrument. So, use an alcohol wipe. I have my assistant always sitting with an alcohol wipe in her hand. And, I'll take my instrument and she'll just wipe it with an alcohol wipe. So it leaves a little smear of alcohol. The alcohol will evaporate, but it'll prevent tug back of the glass ionomer. So if I can give you one nugget, one tip, a trick for placement, it's wetting your instrument with alcohol to sculpt. Always wet it with an alcohol wipe, or, you can have 2x2s in a jar and have alcohol, pour alcohol over them, keep it tightly closed, and you can use those. You can use 2 mm increments and, do this in increments if the preparation is really deep, if it is really large. Otherwise, you can bulk fill it. And we talked about the finishing, of course, light curing it. This, not recommended. So once in a while, if necessary, you can finish, you can even polish. If you can get by with sculpting and get it to where you want it and avoid this step, then you're well advised to do that. So this is the befores and the afters. This material was Fuji 2LC. Before we were using, Fuji 9GP and then Equia, the true glass ionomers in a big way. We were using Fuji 2LC in most applications. So here replacing 2 class 5 amalgams with some recurrent decay on the gingival margins with Fuji 2LC. Class 5 situations. So in these situations, this again is a product from GC, and I'm not aware if other companies are making it, they might be, but this came about, or this was developed in response to a lot of practitioners. Of course, my opinion was not asked for, but if it was, I would have said this myself. One, a lot of dentists don't have a triturator or an amalgamator anymore in their practice. We do. That was not our problem. But the problem is the capsule, it comes in one size. So whether you have a small little pit and fissure lesion to fill, you have a large MODBL situation, you have one size that must fit all. So there is a lot of waste. If you're doing a small class 5, you're doing a small class 1, you waste a lot. And of course, if you're a practice that doesn't have an amalgamator, this is a 2-paste system. So Fuji Automix LC is a 2-paste system. It comes with this ergonomic dispenser, so you don't waste as much, even though there is, some amount that's wasted because it has to mix. The 2 pastes have to mix in this little spiral tip. Still a little less waste than, in the powder liquid system in the large capsules, and you don't have to have an amalgamator. I guess it is also handy if you're going to use it at a mission trip out in the field. You don't need an amalgamator. It mixes in this spiral tip here. And you can simply inject it into the prep, so some advantages to this. It is a light cured material. It is not a conventional glass ionomer. It is not a liquid powder acid base reaction. It does have some composite resin added. So technically it is a resin modified glass ionomer. It is the letters LC, it's light cured. 2-paste system. It does minimize the air bubble entrapment because, the material is mixing in this long spiral tip here, does have better consistency, but it is not a true glass ionomer. The true glass ionomers, which, have the best chemical bond to tooth structure, the best fluoride release, therefore the best known karyostatic properties of any material known to dentistry at this time as a restorative materials, are the conventional glass ionomers. No composite resin added, strictly a conventional glass ionomer with an acid-base setting reaction. Equia and Equia Forte are examples of true conventional glass ionomers with all these properties that we've talked about, not just the chemical bonding and fluoride release, but also the moisture forgiveness, the thermal coefficient of expansion being similar to tooth structure. And that's a very big deal, the thermal coefficient of expansion being the same as that of tooth structure. So Equia has now been shown to be a reliable long-term restorative solution among the true glass ionomers on the market. And really, I myself am aware of only the other one from the company called SDI, and they make a product called Riva. In my practice, I've always used the materials from GC only because of my familiarity with these products. We use them in dental school. We taught them in dental school, and I've continued to use them in my practice. Like I said, SDI is the only other company that I know of that makes true glass ionomers and markets them. So most of the research that you will find in the scientific literature is really on GC products, I guess, because they've been used the longest. So this material was developed with feedback from dentists, because if you think about it, for direct restorative materials, we had amalgam for the longest time, a superb material with wonderful long-term results. I would venture to say we have not yet found a material to equal amalgam in its long-term success. We have not yet found a material to equal amalgam. But since more and more, either for purely aesthetic reasons, for other reasons, people just don't want metal in their mouth. They just won't have metal in their mouth. And then, of course, for the huge, reasons connected to the use of mercury, contaminating our waters with mercury waste from dental offices, which is a bigger problem than most of us think. It is a huge problem. And of course, it will continue to be a problem even if we don't use any amalgam, because we'll be cutting out old amalgam restorations for a long time, right, during our lifetime. We needed an alternative to amalgam for these reasons, right? The alternative, composite resins, which are extremely aesthetic, wonderful for anterior use, in posterior usage have the disadvantage we've talked about, which is the polymerization shrinkage, zero forgiveness to moisture. They're hydrophobic materials. They recoil from water. They don't like water. So they're used in class 2 situations where you cannot have good isolation at the gingival margin. Their polymerization shrinkage, huge problems, create marginal leakage, recurrent decay, right? Huge problems. They're not very biocompatible with tooth structure. They have zero chemical bond. The only bond is because of the etchant. It's micromechanical. And of course, we've come a very long way in creating that hybrid layer and coming up with good micromechanical bonds. Still, there is no chemical bond. So in order to combat those shortcomings of composite resins in large and deep posterior situations, posterior caries, comes into the market, true glass ionomer materials. And like I said, Equia from GC was a sequel to their first true glass ionomer, which was Fuji 9GP. And we used Fuji 9GP for a long time at the dental school. I used Fuji 9GP for a long time in my private practice. But Equia then came around, and Equia was much more aesthetic, had more translucency, again, nowhere close to composite, but much more translucent, much more translucent than Fuji 9GP, and had a huge difference, much greater compressive strength than Fuji 9GP because of the filler particles that have been added to Equia. So Equia Forte is fortified because of the filler particle, the volume of filler particles. So increased durability, giving us the confidence to use Equia Forte as a bulk filling material for these situations. Permanent molar, young person, this person is only 15 years old. In my practice, tooth number 14 had hidden caries, where the enamel was still intact. And I really regret that I don't have a preoperative picture, but you're opening it up thinking it is a small incipient pit and fissure lesion, and your burr just drops. And there is this huge lesion underneath. The whole thing. And again, we used, and this was not a lingual Toffelmeyer. It was just the regular Toffelmeyer band. Used it from the lingual though, because the greater part of the mesiobuccal cusp is gone, but restored, with Equia Forte. Again, the trick is to use an alcohol-wetted instrument to sculpt it. And another trick is to make sure that the band is lubricated. If the band is not lubricated, the tendency of the material to stick to it is great. So many times, you'll either damage chip out or take away completely your marginal ridge when you remove the Tafelmar band if it's not adequately lubricated. So this adequate lubrication is very important. And this is a video, if I can play it. Okay, this is meant to show that, you know, you can use your cleoid discoid instrument here to sculpt, carve, make sure you get it, you know, have your assistant wipe it with alcohol as you're going around, and then spray with water, which I hope the water spray is coming on this video. Make sure that you do not allow it to desiccate as you're working with it. You know, it is still in that setting phase. You have a long time. You have 2 minutes to do this, but make sure that you spray it with water. I didn't see the water here, but the finished product. And you can really get very good anatomy, you know, using this material. You can get very good anatomy because you have enough time to work with them. You can use, if you get really fancy, you can use, you know, tints and opacers, because if you're worried about aesthetics, generally in the posterior situation, you won't be. If you're doing a class 5 on a premolar and it really does show the smile line is high and it does show when the patient smiles, you can use some tints and opacers, but, you know, chances are you're not going to use that too much. The clinical performance of during 48 months of 2 current glass ionomer restorative systems with coatings. This was a randomized clinical trial, and really a nice trial, 48 months long, but it looked at Equiafill and Fuji 9GP, both with surface penetrating sealant coatings. Okay, and they found that there was not a big difference. They were used in class 1, class 2 situations in 643 patients on permanent molars, and they didn't show a significant difference. But this is the landmark study from Operative Dentistry 2015, 4-year randomized clinical trial evaluating the clinical performance of a glass ionomer restorative system, where granted, the size was not as large, the sample size, as in the previous study, but 4 years of follow-up, 126 restorations, 76 class 1, 50 class 2, on 52 patients. Recall rate was very high, 88.1%. None of the restorations, and I'm reading from the results, showed trends to downgrade in anatomical form, secondary caries, surface texture, post-op sensitivity, and color match. This is after 4 years. So, you know, for significant differences in marginal adaptation and discoloration were found compared to baseline for both restorative materials, which is both Equia Forte as well as Gradia, the composite resin. Both showed, of course, you know, some change in marginal adaptation and discoloration at 4 years, but both the materials were clinically successful, equally clinically successful after 4 years, with a very high follow-up rate. So these are the materials used in this study: Equiafill with coat, which is a surface penetrating sealant. So the coating material that comes with true glass ionomers is basically a surface penetrating sealant. So it's basically, and think about it as an unfilled resin that penetrates into these micro cracks. You'll air dry it, you know, get rid of the solvent, and light cure it. So it's basically like, you know, if you're pouring a concrete driveway, you'd pour your concrete and then cover it with a sealant. In this case, of course, in our case, we're using a resin and it's light cured. And the material, the composite that they compared it to was Gradia Direct, a microfill hybrid composite. And this is its composition. Like I said, there were 126 or 140 restorations that were done. 70 with Equia, 70 with Gradia Direct, for a total of 140. Okay, so this is the distribution between maxillary mandibular premolars, molars. So that was the landmark study, and they did it really well. 2015 Operative Dentistry. This is showing you some scanning electron micrographs, and you can see Equia on this side, enamel on this side. Look at the marginal adaptation. The marginal adaptation is just beautiful. Underlining and emphasizing one more time the chemical bond of the material and its thermal coefficient of expansion being similar to that of enamel and dentin. That's a very big deal. So high viscosity glass ionomer cements, as they're called, the true glass ionomers. So recall, we're talking about the true materials which set with an acid-base reaction. They can be sold in those capsules or bottle, two-bottle system, powder liquid system. In the end, they're powder liquids, acid bases. So this is the evidence in brief for their use in direct posterior tooth restorations in permanent teeth. Again, not to be used as interim or long-term temporaries, but direct posterior restorations in permanent teeth. So the evidence, lab trials, uncontrolled clinical trials, controlled clinical trials, these are the sources of the evidence with the high viscosity glass ionomer cements after conventional cavity preparations, by drilling, and controlled clinical trials following atraumatic restorative treatment where no drilling was used. The caries was only excavated using a spoon excavator. So both the drill technique and atraumatic restorative, or ART, they were assessed based on systematic reviews and meta-analysis. And this is important because when they combine the data, and they use 38 controlled clinical trials, over 10,000 tooth restorations for ART, the review results indicate no statistically significant difference in the failure rate between high viscosity glass ionomer cements and amalgam restorations in single and multiple surface tooth cavities for up to 6 years. So to me, another landmark study, and this is much more recent, this is 2016, so from the Journal of Dentistry, 2016. So this is huge. 6 years of follow-up, 10,000 restorations. So the consensus from the Journal of Dentistry 2021 on glass ionomer cement thresholds for restorative indications suggests that we can use these with confidence on premolars, molars, permanent teeth, class 1, class 2 restorations. Okay, so you can look that up for sure. But I wanted to spend just a few more minutes here. This is a 1-year comparative clinical evaluation of Equia, again, the material from GC, with resin-modified glass ionomer and a nanohybrid composite in non-carious cervical lesions. And I think most of you, if not all of you, will agree that restoring a non-carious cervical lesion and doing that successfully is tricky. And I think that might be in the direct restorative realm, probably where I've had the most failures personally. You fill a class 5 non-carious cervical lesion, deep abrasion, abfraction, erosion, what have you, with a composite resin. And, sometimes within days, sometimes in months, but less than a year's time, catastrophic failure. The restoration is lost. And of course, those are the days when the patient sits and talks loudly about that in your waiting room, in the presence of others where they can hear it. Very embarrassing. So I was very curious to see what this study said, and they found no significant difference between Equia, a resin-modified glass ionomer, and a nanohybrid composite at 1 month, 6 months, and at 1 year. So it was as good as a composite resin to use either the true glass ionomer or a resin-modified glass ionomer. So good to know. I have switched to using a true glass ionomer in 100% of my non-carious cervical lesions because the gingival margin is almost always subgingival. You cannot get good isolation there anyway. So why not use a material that is forgiving of moisture? So, and it is very easy to use bulk fill for the true glass ionomer. So this is the material from SDI, the Riva Self-Cure bulk fill glass hybrid restorative system. And again, the same sort of, packaging as the system from GC. It is a powder liquid with a plastic separator in a capsule that needs to be triturated. Doesn't seem to be any different. My experiences with the GC products, again, for the reasons that I mentioned before. Another young person, hidden caries, tooth number 13 and 14, large carious lesion on another very young individual. Permanent teeth, permanent molars, permanent molar and premolar rather, restored number 15 previously with, I think that one is a composite resin in this OL restoration here. Both these were done with Equia Forte. Again, easy placement. Must remember that the tooth structure should never be desiccated. Leave it moist. Use water. Once the material, when you're placing this material, it has reached a dough-like consistency, use water. Have the assistant spray water, and then use your, I use a football burnisher, use a clear discoid to carve it, or use a football burnisher to carve or to sculpt it completely, using an Almor or some plastic filling instrument on the axial surfaces to sculpt. So we're now looking at an X-ray, and I apologize if it looks a little grainy. It looks a little granular on my screen, but here again, tooth number 14 and 15, large old amalgam restorations. And I don't know if it is visible, but there's huge amounts of recurrent decay. Let me see if I have a PA here. I do, but that PA, for whatever reason, looks granular. I hope that you can see the amount of recurrent decay here. This is the same tooth number 14, huge amount of recurrent decay. The amalgam on 15 was fine. This is the clinical photo. Left the amalgam on 15, restored the entire 14, this MODL with Equia. The entire thing. The lubrication of the band while placement of the material is critical. So lastly, wanted to speak about, in vitro abrasion, the wear resistance of resin-coated highly viscous glass ionomer cements, the HVGICs, using the SPS or the surface penetrating sealant. GC calls it for Equia, the Equia coat, basically thinking about it, like I said, as a sort of an unfilled or low resin with low filler volume, sort of a flowable resin there. When you look at a confocal laser scanning microscopy study in this case, and multiple studies have been published. I just present one here for us, looking at the wear resistance. And here they used a toothbrushing simulator, a machine, and they looked at the wear after 40,000 cycles, as if, the patient had brushed with a toothbrush and a slurry of toothpaste. But they found that the tooth wear loss was similar with or without coating in this case. And then in many other studies, they have shown that the wear was significantly reduced after the use of the surface penetrating sealant. So I have taken to using that, surface penetrating sealant, Equia coat in all cases. It comes with the material. Here they have use the SDI, the Riva material, as well as the GC material with and without coating, and found the wear to be similar with and without coating for both, for Riva as well as Equia. I use the SPS in almost all situations. It provides not just a surface penetrating coating. And if you did introduce some micro cracks into the material, you did allow it to dry a bit, or you had to touch it with a burr because you were unable to finish it completely in the 2.5 minutes or so that you had. You can, then fill those micro cracks with this material. It also provides that nice luster. If the patient's tongue goes over the material, it has that nice lustrous finish. The other fringe benefit of using the surface penetrating sealant or the coat, the resin coating after doing a true glass ionomer restoration, is that in the patient's mind, and this I've learned because I've used these materials almost exclusively now for my posterior direct restorative work for a decade or so. The patient says, if you don't use it, they say, you didn't use that blue light. Am I not getting a tooth-colored filling material? So there's a fringe benefit. You use a true glass ionomer, but after you use the coat, you light cure it. In the patient's mind, all the boxes are checked. You used a light, so you must have used a tooth-colored material. In 1 second, my time is almost up. I wanted to say these materials, especially the true glass ionomers, Aquia Forte and the Aquia Forte HT in this case, which is this high translucency, for patients with special needs, for patients with rampant caries. These materials are most definitely materials of choice. So this is a person with special needs. They, I had worked in my special needs clinic at Southern Illinois University for over 10 years, could get very little, if any, cooperation, very little isolation, huge carious lesion. We managed to get a Fuji 9GP restoration. So in those days, we had Fuji 9GP, which was the precursor to Aquia. We talked about what Aquia does better than Fuji 9GP, but the patient was very combative, severe physical, intellectual disabilities. We were able to get this in. And really, in my practice now, I have a follow-up of 4, 5, 6 years on these restorations. But I will end here and allow a few minutes for questions and answers. All right, so let's see. I have a question that says, is Fuji 2LC dual cure or only light cure? Fuji 2LC is light cured. It does have composite resin, so it will be light cured. There are more questions around the same line. And then there's a question that asks about, is there a difference between dentin conditioner and cavity conditioner? No, as we said, there is none. Are resin-modified glass ionomers less moisture tolerant than true glass ionomers? This is a very good question. Are resin-modified glass ionomers less moisture resistant than true glass ionomers? Yes, because up to 20% of the material, recall, is now a composite resin. So there is an element of resin, even though it is 20% or so. So there is some, hydrophobic material in them, and you are in the end light curing the material. You are polymerizing whatever composite resin is in there. So there is a level of, isolation that you need. True glass ionomers are truly acid-base reactions. They need water for the reaction, like we talked about. What do you lubricate the Toffelmeier band with? Excellent question. No, not alcohol on the Toffelmeier band. I use right now PAM cooking spray. So if you're a cook and you've used, cooking spray, it can be any brand. I happen to be using PAM right now, but you can use any brand of a cooking spray. You can use a crayon, any crayon, a child's crayon, a Crayola crayon. We used to use crayons all the time. They sell crayons in dentistry for this exact reason, but you can use a Crayola crayon, any crayon, but they dry up when they sit around in your drawer. So the cooking oil spray works beautifully. There are several people who have asked about the lubrication of the band. So you'll one person has asked about, will Vaseline do the same thing? It will. And for the longest time, I did use Vaseline. It becomes difficult because you have to take it in a sort of an infection control manner with a Q-tip from the pot and then apply it. Sometimes my assistant would leave a glob of Vaseline on the band. The cooking spray, leaves a nice uniform coat, no globbing. So that's why I really like it. Many of you have asked this question about lubricating the band, and this is critical. So if you've learned nothing else from this hour, lubricating the band and adequately using water when placing the material are important, and using alcohol. Many have asked about alcohol. What do you mean by hidden decay? Very good question. What I mean by hidden decay is where the enamel is not really broken at all. The enamel appears intact. There could be some discoloration, but and you may see this on an X-ray, on a periapical X-ray, or even a bite wing. Only when the decay becomes very large. The bacteria have had a party in dentin. There is a huge lesion in dentin. The enamel is unbroken yet. So it's like it's covering a hollow cave. It's unbroken because it has so much fluoride in it. you touch it with a burr and you fall into this decay. So it has been written about, and you can look at the literature and just search for hidden decay. So occlusal adjustment. Yes, there's a good question about occlusal adjustment. When you do occlusal adjustment, you can use a burr. I tend to, look at this. I teach operative dentistry. Look at the occlusion before you fill, and then, carve it, bring it down to where you need it. But definitely, once it has set up, can you use a burr for occlusal adjustment? Definitely. Do the occlusal adjustment first, and then nicely, rinse it, dry it, and apply your surface penetrating sealant. And I think I might be able to answer one more question before the hour is done. The open sandwich technique, really the open sandwich technique, as I showed in the picture, is where the glass ionomer base or the resin modified glass ionomer base will be taken all the way out to the CAFO surface margin on the gingival floor, and then cover up on the top with composite resin, just because composite will give better wear resistance. But I tend not to worry too much anymore about the wear resistance, because I have had really good long-term success with these materials. With that, I think I have come to the end of the hour. My time is up. So I'd like to thank you all for this opportunity to talk to you. Thank you.